Hello and welcome to this session of the Center for Podiatric Education. This is an expanded version of a short presentation that I was recently asked to give at a local residency meeting, and it's a reflection of philosophy of practice as well as a reflection of the manner in which I treat patients in my office on a regular basis. It's a discussion on the use of compounded medications in the management of some of the more common foot and ankle disorders that all of us see in our practice on a daily basis. It was interesting to me that the program director for this meeting asked me to give a topic or cover the topic specifically on why I use compounded medications more than you do. And the topic sort of surprised me, but again, it is reflective really of the manner in which I practice daily, and I'm hoping that some of the things we discussed today will be of immediate use to you in your practices, and I hope you give this a serious consideration. The use of topical medications has expanded my ability to treat patients for a variety of concerns and complaints for which they come to the office, and I have used them with success in many patients. So why do I look at compounded medications, for example, in wound healing? And that is because in the case of ulcer healing or in the case of individual pathologic conditions that we see, such as Achilles tendinosis or plantar fasciitis or plantar fibromatosis as examples, compounding allows me to individualize treatment. So I could look at a patient and determine what do I need for this patient and create a specific compounded cream to meet the needs of that patient rather than being product oriented. When I say product oriented, I mean we look at a patient, for example, a wound or a patient with Achilles tendinosis, and we say at times what product, what prescription, what medication am I going to write for, rather than saying what is it that this patient needs. And oftentimes that requires multiple medications, multiple therapeutic interventions, and with compounding I could provide those multiple therapeutic options really all at the same time. And it allows me to provide that when these options are either otherwise not commercially available, or it would require me to write 2 or 3 prescriptions at the same time. Now, the key is to understand that compounding and the use of compounding pharmaceuticals is not a substitute for things that you normally would do. It is adjunctive, and it's used in combination with other principles for the care of those conditions for which you're seeing that patient. So it's an extra step, if you will, and it proves to be of tremendous benefit to patients. I can't emphasize enough what good luck I've had with compounding. So what are some of the advantages of peripheral administration? Well, for one thing, it optimizes the concentration of the drug, sometimes as much as 100 times greater concentration at the site of the pathology rather than giving the same drug by mouth. So a good example would be Achilles tendinosis, or perhaps a nerve entrapment associated with a dorsal exostosis, overbone deformity, if you will, and maybe compression of the medial proper branch of the medial dorsal cutaneous nerve or the medial terminal branch of the deep peroneal nerve. The skin is thinner there. I can get an anti-inflammatory, or I could get a drug active for nerve pain, or an analgesic concentrated right where I need it, right at the site of pain. I don't have to worry about systemic levels of these medications. I find that oftentimes as podiatric physicians, doctors are reluctant or have a reluctance to get involved in treating things, for example, peripheral neuropathy with diabetes. and you have a patient that's suffering from paresthesia or dysesthesia perhaps, and many people will say, I don't want to write for clonidine, I don't want to write for amitriptyline, I don't want to write for gabapentin, and yet you could take those same medications and apply them topically without concern for elevated systemic levels of these medications. Uh, an excellent example really is that of oral anti-inflammatories with all the potential known risks and potential complications. So I have a patient, for example, that might be on anticoagulant therapy for atrial fibrillation, and I want to give them an anti-inflammatory, but I'm concerned about the interaction affecting the serum levels of their anticoagulant. I could give that medication topically and not be concerned with drug interactions, really not be overly concerned about systemic levels. So you do have some absorption of topicals, and it's been estimated that between 5 and 15% of the medication is absorbed. As a result of the fact that we're applying this locally and the fact that we are not giving it by mouth or by injection, we would expect, and in fact we know, that there's a reduced incidence of side effects. So can you get adverse sequelae from a topical compounded medication? Of course you can. Somewhere around 10 to 15% of patients may develop a contact allergy or a primary irritant sensitivity to one of the components, or perhaps one of the carrier molecules. But as far as systemic side effects go, while we still want to monitor patients and ask about potential adverse sequelae, we really don't see it nearly as frequently. Similarly, drug interactions. There are times that we want to perhaps give a medication to a patient to assist them in reducing inflammatory changes or reducing pain, but we're concerned about drug interactions. This is far less a concern when you give that medication topically. Generally, titration is not an issue. Again, if we look at drugs like gabapentin, we will generally titrate that drug over time, starting at a lower dose and gradually increasing the dosage. When we do this topically, we get over that problem. And of course, it's easy to use because it's simply applied topically, and in most instances, this is not an issue. One of the things that peripheral administration allows us to do, again, is treat problems that we normally would not treat because we're concerned about these issues listed here with regard to writing an oral prescription. And what this does is allow for expanded practice opportunities, quite frankly, so that many times we have patients that we see for, quote, routine care, for example, and they may require treatment for neuropathy or for vascular disease or for arthritis. And because of the comorbid conditions and because of the medications we're taking, because of this list of considerations that we're looking at right now, there's a reluctance to get involved in treatment. And yet we know that topicals are very effective for many patients, and it expands our ability to treat these patients safely, and it leads to an increased use of the 24 and 25 modifiers, because I could see these patients for so-called routine preventive care, additionally safely treat them for their neuropathy or vascular disease or other issues, some arthritic condition, tendinitis, whatever it may be, and it allows me to treat them for associated pathology, just not their, quote, routine foot care. Now, we know that topicals can be helpful in improving soft tissue and bone healing. One of the reasons that we don't hear a lot about these medications and studies on them, although there are many studies to show the effectiveness of topicals, is that most of these medications are generic. And so there's not the financial incentive to go about and develop these drugs in their compounded formulations. And yet, if you think about it, in treating topical or treating inflammation, tendinitis, arthritis, pain, inflammatory skin disorders, infections like tinea pedis. We use topical medications frequently in our practices, so we know that topical medications are quite effective. But again, because no one is out there marketing these things, most people are not familiar with the literature. And one of the big issues is when we use compounded medications, there's frequently no third-party coverage. And this is definitely an issue. And the key to compliance, in my opinion, is sitting down with the patient or their family or a designated caretaker and explaining why the patient requires that compounded medication, explaining the benefits of the compounded medication, acknowledging the fact that yes, we know there's no third-party coverage. Generally, these are not covered by insurance, but why it is to the advantage of the patient to go ahead and obtain that prescription. So I oftentimes use compounded medications for what I consider to be difficult clinical problems or surgical pathology. For example, I'm not one who's very enthusiastic about retrocalcaneal surgeries, and insertional Achilles tendinosis is an example of a problem that I would prefer to treat non-operatively whenever possible. And it's been my experience that together with other therapies, topical medications can be extremely helpful in resolving some of these issues. We have some patients that again have issues with polypharmacy, multiple comorbid conditions, and really are not ideal candidates for oral medications, and yet we can provide the same medication that we would provide orally topically. We all have those patients that say, doctor, I don't want to take any more prescriptions, I'm taking too many prescriptions already, or the patient who generally is opposed to taking medications. I find that when we talk to these patients about topical compounded medications, and again, it comes down, in my opinion, to education of the patient and their family, that they are willing to accept a topical medication or a compounded medication, even though they will not accept that same medication or medications by mouth. We have the patients that simply don't want surgery for whatever reason. They have surgical pathology, they have pain, and here again, compounded medications are helpful for some of these patients in resolving their symptoms. The patient that normally would be injected, and yet we all have those patients that say, I don't want any injections. Here again, I find that topical compounded medications can be helpful for these patients. Patients that have chronic pain syndromes of the foot and ankle, and we look at these patients and we're looking for alternatives to opioid analgesics, alternatives to chronic oral analgesics. Here again, topical compounded medications can be extremely helpful. I find that they are extremely helpful in managing chronic inflammatory conditions such as tendinitis, capsulitis, problems such as that. Again, together with other therapeutic interventions, and then just conservative care in general as part of initial treatment protocols, saying, before we rush into surgery, before we rush into invasive procedures, why don't we try this? And a substantial number of patients do well. So with compounding, depending on the problem, I can, instead of wondering what product I'm going to write for, I could say, what does my patient need? And is there a combination of products available that I can provide them with? And the answer is generally I can get these medications topically when they're compounded. They may not be available commercially, or they may be available but not in the strength, not in the concentration, not in the combination that I want. Because ultimately what we're looking at here is better treatment of our patients. So this is site-directed therapy, compliance is easier, and another issue is that of multiple medications at one time. So let's take the issue of wound care, for example. I can look at a wound and say, okay, this wound is painful, I'd like an analgesic. Perhaps I want to debride the wound, and I may want to prescribe a collagenase or salicylic acid or urea. Perhaps I want to reduce bioburden and utilize a topical antibiotic or analgesic, or possibly an antifungal. And all of a sudden, I'm looking at 3 or 4 prescriptions being written. Each one, of course, is going to have a copay. Each one's going to have to be applied separately. And yet I could look at the patient and say, I think these are the things we need to do with your wound at this time. And I'm going to write for a prescription for a compounded cream, because this will allow us to do multiple things at the same time, rather than me writing 3 or 4 prescriptions and you having to pay 3 or 4 copays and apply 3 or 4 creams. So it also allows me to do things that normally I can't do. For example, topical phenytoin or topical statin drugs have been shown to be helpful in stimulating epithelialization, stimulating healing. So these are things that typically I cannot get. I could also add, for example, collagen at the same time. Another example would be plantar fasciitis or plantar heel pain. We know that the etiology of plantar heel pain, while it is typically plantar fasciitis or plantar fasciopathy or fasciosis, whatever you believe is the etiology, we may want an anti-inflammatory component, we may want an analgesic component, we may want a muscle relaxant component, we may feel there's a nerve involved, perhaps a branch of the medial calcaneal nerves or Baxter's nerve, and we may want something that's effective on the local nerve and calm that down. And here again, compounding allows me to treat multiple potential etiologies at one time, rather than writing for 3 or 4 products. Now, I get this question periodically, and they say, aren't you using some of these drugs off-label? For example, using phenytoin for wound healing, or misoprostol for wound healing, or using topical atorvastatin for wound healing. And this is not something that's actually regulated by the Food and Drug Administration. And as you can see, the Federal Food, Drug, and Cosmetic Act does not limit the manner in which you utilize an approved drug. This is a matter of your judgment. And so if you have an approved medication and you determine that it's the patient's best interest to utilize the medication in whatever manner you see fit topically, you certainly are free to do that. And again, one of the big benefits that drives me to utilize compounded medications quite a bit is right here, and that's the fact that the plasma concentrations are generally extremely low compared to giving the same medication by mouth, and it makes me very comfortable and not fearful for things such as drug interactions and affecting serum levels of other medications or exacerbating comorbid conditions. And increasingly we have an aging population, and increasingly we're dealing with patients that have multiple comorbid conditions, and topical therapy becomes a consideration in treating these patients, increasingly so. So one of the things I do is, of course, establish my diagnosis and my differential diagnosis just as you do. I consider a total treatment plan, and I consider the use of a topical compounded medication versus alternatives in terms of cost, obviously, in terms of potential risks to the patient, and in terms of alternatives. And I'll say again, I think the key to compliance is communication with the patient or their caretaker. Now, a good example are elderly patients that are coming to see us, and they have many times multiple comorbid conditions. They may have atrial fibrillation, they may have congestive heart failure, they may have a cardiac valve. Our diabetic patients may have renal concerns. They may have some degree of chronic kidney disease, declining renal function. We have many patients that are on anticoagulants for a variety of reasons. We have patients that are being treated for hypertension. We have patients that have a GI history. So for all of these patient concerns, all these comorbid conditions, we know that oral anti-inflammatories are potentially going to exacerbate those conditions. So in those patients, we say, well, what are we going to do? And we look at our alternatives. And one alternative is no treatment and just say, I'm fearful of exacerbating your comorbid conditions, and therefore I'm not going to treat you at all. Perhaps we try to skirt the issue with physical therapy. We may go ahead and prescribe oral medications and monitor that patient for side effects. We may say, well, I'm going to go ahead and utilize injection therapy. We may proceed with surgery, arguing that oral medications are actually more dangerous. But in such patients, I think a consideration should be given to topical medications, and in particular, compounded medications. So looking at common inflammatory conditions we see, such as plantar fasciitis, Achilles tendinosis, various tendinitis, peroneal tendinitis, whatever, capsulitis, I will utilize a combination of diclofenac, baclofen, and lidocaine typically to be applied 1 to 3 times daily. Now this is together with standard therapies. So again, these are very, very common indications for this combination of compounded medications. It allows me to achieve pain relief. It allows me to provide anti-inflammatory therapy, and I can do so feeling rather safe that the patient's not likely to have adverse reactions to therapy. Now, again, it can occur. Topical therapies are not without potential adverse sequelae, but the incidence is going to be extremely low. So in these common arthritic and inflammatory disorders, I will go ahead with that combination of diclofenac, topical lidocaine, and baclofen. Plantar fibromatosis is another example. We know that this is a condition that is associated surgically with a high rate of reoccurrence. It is associated with a high risk of nerve injury, either because of invasion or compression of the fibromas on the nerves in the area, or as a result of our surgeries with the scarring, unfortunately. So I explain the pathology to the patients, and I say, listen, you know, I want you to stretch out the plantar fascia. I want you to get a confirmatory MRI, and I explain to them that if these become significantly painful, that we're likely going to have to go ahead with surgery, perhaps a dermatofasciectomy if the lesions are adhered to the dermis, and a more radical excision if there's a more invasive form of their disease. But I find that most patients, if they understand the surgical risks, that they are more than willing to engage in non-operative management with stretching and splinting and the use of topical therapy. And here is an example of a condition where my preference is not to do surgery and where I've had wonderful success. And I would counsel all of you to consider seriously the use of topical therapy for plantar fibromatosis. Now, in treating plantar fibromatosis, I utilize topical verapamil at about 15%. That is because verapamil is a calcium channel blocker. It is helpful for inhibiting the production of collagen, and we know that when we inhibit the production of collagen, we also stimulate the production of collagenase. I combine that with diclofenac, 3 to 5%. And I also incorporate 5% lidocaine for pain relief. And I use this again in combination with stretching and splinting and an accommodative insult. And I find that if patients understand the reality of the potential complications with their surgery for fibromatosis, that they will be very, very compliant. I do follow these patients up. I do get a confirmatory MR or ultrasound, and I've had wonderful success in softening these fibromas. And does this resolve them? Totally, of course not. But if the patient is pain-free and able to engage in all of their normal daily activities without restriction, both the patient and I am very, very pleased. Certainly, onychomycosis is a subject of great discussion in our profession, and while the majority of these patients have a dermatophyte, typically T. rubrum, less commonly, as you know, T. mentagrophytes or epidermophyton. We also see a lot of patients with superficial white onychomycosis, but we also have patients that have saprophytic fungi in addition, and at times candidal infections. And I think we probably don't realize just how frequently Candida or Pseudomonas are involved, particularly in our immunocompromised patients. And of course, these nails are thickened and they're difficult to reduce. Now, ideally, we are best going to treat these patients with oral terbinafine if it is a dermatophyte, and itraconazole for saprophytic fungi, and fluconazole orally if it is a yeast infection. But again, many are reluctant to pursue oral antifungal therapy, particularly in elderly patients or patients who have significant comorbid conditions, or again, the issue of polypharmacy. So in that instance, I prefer broad spectrum antifungal therapy. So typically I will compound amphotericin B with terbinafine, thymol, and urea. This accomplishes many things. It gives me broad spectrum coverage for patients who have dermatophytic infection or saprophytic infection. It allows softening of the nail so that in fact, frequently get quite a bit of lysis between the nail plate and the underlying nail bed. It allows more effective debridement. If there is a yeast present, I can include fluconazole. And here again is a perfect example of the benefits of compounding. I can say if there's a yeast present, I could add fluconazole. If there is a saprophytic fungus, I could compound up with itraconazole, frequently using certain anti-inflammatories such as ibuprofen. We get a synergistic effect between the antifungal and its effectiveness on these nails. So one can proceed to culture these if you're going to actively treat these, confirm that it's an onychomycosis. One can confirm with PAS, one can confirm with the cultures. But again, utilizing compounding, I can do multiple things at one time. I could add topical gentamicin if I think there is a Pseudomonas component, or if the nail tests out positive for Pseudomonas. So compounding allows me to do several things. I could soften the nail, I could improve the peri-ungual keratosis that's present, I could treat a dermatophyte, I could give broad spectrum coverage. And generally it's recognized that patients with diabetes or peripheral arterial disease, immunosuppressed patients, patients with lymphedema, chronic venous insufficiency, these patients that get recurring episodes of cellulitis, that we should be actively treating these patients, not just reducing their nails. Now, you have a variety of therapies that can be utilized in an effort to identify the fungus. And here again, these range from doing a PAS, which is very, very sensitive, but not species specific, to fungal cultures, or using various DNA testing for the nails with various sensitivities. So the question becomes, do you need to confirm the onychomycosis or not? And if you are going to use a therapy that's either expensive, like an expensive topical, or if you're going to be using a therapy that's potentially dangerous to the patient, such as oral and fungal therapy, then we go ahead and recommend genetic testing or culture, because you want to speciate to make sure that your therapy is justified. Some of the expensive topicals, as you know, are or have been shown to be effective only for dermatophytes, and really they have limited application at that. If you simply need to confirm the fact that it is a fungus and speciation is not required, then PAS, possibly dermoscopy is the issue. So while we have a variety of manners in which we can treat onychomycosis, I like broad spectrum therapy. As far as lasers go, here again, lasers are not species specific for onychomycosis. Therefore, all we really need to know in administering laser therapy is yes or no, is it a fungus? Because we don't have a separate laser for dermatophytes or for saprophytic fungi or for yeast. And then, again, it's generally recommended that patients who undergo laser therapy be told that this is not going to be curative, that this is only going to temporarily improve the appearance of the nail. A big area of compounding in my practice, and one that I hope you really consider, is that of treatment of symptomatic neuropathy in older patients. We know that idiopathic neuropathy is common. Neuropathy with aging is quite common, and while generally diabetes is the most common cause of paresthesia and dysesthesia, we do have other etiologies of neuropathy that we see that may be related to endocrine or metabolic disorders, drug-related neuropathy. We know that patients who take metformin have an increased risk of peripheral neuropathy due to the effects of the metformin, and this is often associated with a deficiency in folic acid or deficiency in B12. And in looking at neuropathy in our patients, we have two levels. We have the patients who have non-painful neuropathy, that is to say, as you know, this is characterized by numbness, and these are the patients that frequently get the Charcot joints and the ulcerations and the bad infections. And then we have quality of life issues, the patients that have significant paresthesia and dysesthesia, and we certainly want to work these patients up and rule out other causes of their neuropathy. Generally, advanced testing with studies such as nerve conduction studies are not required. We know that standard testing with checking of reflexes for the presence of motor neuropathy, vibratory perception, temperature perception, and pinprick and light touch is more than sufficient to diagnose the majority of patients with neuropathy. And then the question becomes, what are our objectives of treatment? And certainly, if possible, we want to interdict the progression of that neuropathy. We want to recognize the effects of that neuropathy in terms of motor deficits and skin deficits from autonomic neuropathy, swelling from autonomic neuropathy. But I want to talk about painful neuropathy for a moment. And again, we have a variety of medications that are established as effective for the treatment of painful neuropathy. The problem here again is that while many patients complain about paresthesias and dysesthesia, and you may want to treat those patients, the fact is that you're reluctant because you're concerned about side effects from pregabalin or gabapentin or amitriptyline or duloxetine. So the SNRIs, the tricyclics, the anti-seizure medications, perhaps the concept of using long-term opioids or analgesics interferes with or raises enough concern that you don't want to get involved. And I think you will find if you start writing for these compounded medications topically, that many of your patients, together with overall medical care, I mean, you want to make a correct diagnosis and not miss an entrapment neuropathy, or they have uncontrolled diabetes, or they have spinal stenosis, or cervical spine stenosis, or myelopathy, whatever. So you still have to make certain that they have a peripheral neuropathic component as the etiology of their symptoms. But with that done, you're going to find that many patients do extraordinarily well with compounded medications. They're thankful to you for prescribing these things. You want to remember that pain it results from stimulation of multiple pain receptors, and the etiology for the generation of pain can be multiple. And so one advantage of a topical compounded medication, and this is a typical combination I will use, will consist of, for example, gabapentin and amitriptyline and clonidine and lidocaine. And this enables me to attack the patient's symptomatic neuropathy while using multiple medications so I could attack multiple receptors, multiple potential etiologies for the generation of their pain. And I tell the patients, frankly, that I'm cheating. I say, listen, instead of just giving you a tricyclic or just giving you an anti-seizure medication or an antiarrhythmic or something like that, I can combine all these medications in one. And yes, it's going to be a little bit more expensive, but I don't have to worry about neuropsychiatric side effects or swelling or a cardiac dysrhythmia. I don't have to worry about anticholinergic side effects, and really, I could effectively treat your neuropathy with these creams, and many patients do extremely well. Now, the other thing I do is treat them, just as an aside, with therapy if they're on, for example, metformin. I will treat them for their symptomatic or non-symptomatic neuropathy, because the topical compounded medications are going to be helpful for relief of pain in that symptomatic treatment, but I also want to treat them in terms of stopping the progression of their pain and the progression of the neurologic deficit that's associated with their disease. This is particularly an issue in the patient who is taking metformin for the control of their diabetes. And I explained to them that metformin interferes with the activity of intrinsic factor. It interferes with the absorption of folic acid and B12, and that this will raise their homocysteine levels. It will interfere with normal nerve function and repair, and sometimes utilizing the active form of certain B vitamins will be helpful in resolving their symptoms. If the patient does not have symptomatic neuropathy, but they have, for example, numbness, then I'll typically use a combination of L-methylfolate, methylcobalamin, and pyridoxal 5-phosphate. If they have symptomatic neuropathy, then I will also add alpha-lipoic acid as well as vitamin D, together with the L-methylfolate, methylcobalamin, and pyridoxal 5-phosphate. Because these functional deficits are very common in the diabetic patient, and we find even that patients who have seemingly normal B12 levels have a functional deficit. So if we check them for markers of B12 deficiency, such as methylmalonic acid, we find that these markers are elevated even though technically the patient has a vitamin B12 level that's, quote, within normal range. And many of these patients, by simply administering a combination of L-methylfolate, B6, and B12, will respond in terms of decreased paresthesia and dysesthesia. So compounding allows me to look at each patient and say, what do I want to accomplish? Lastly, I want to say a few words about compounding and wound healing. And this is a very important issue in the practice of podiatry. All of us treat wounds. We treat a variety of wounds: diabetic wounds, venous ulcers, arterial ulcers, ulcers with connective tissue disorders, arterial venous ulcers, and so forth. And we debride these wounds, we offload these wounds, and we frequently want to prescribe some product that will be helpful in expediting the healing of that wound. So we tend to pick a product. And there are many excellent wound care products that are out on the market. My thought has always been, what do I need to accomplish with a particular patient and a particular wound? And I think about manipulation of that wound healing process rather than trying to determine what product is it that I want to use. And compounding allows me to look at that patient and the particulars of that patient and the particulars of their wound and say, what is it that I want to accomplish, and go ahead and accomplish that. So I do this together with standard wound care. So all of us know that the wound healing process is characterized by the appearance of a variety of cells and tissues sequentially in that wound if we have normal wound healing, and this is driven by growth factors and is driven by cytokines. There are many things we can do with compounding medications for wound healing. We can stimulate epithelialization, we can stimulate granulation tissue, we can upregulate growth factors, we can reduce bioburden, reduce bacterial and fungal load, we can increase vascular perfusion, we could achieve some degree of debridement, and we can reduce pain. We can accomplish all of these things topically. However, instead of writing for one product, for example, let us say the patient has a painful ulcer. Perhaps it's a venous ulcer or an ulcer associated with sickle cell anemia or connective tissue disease or some such thing. We may write for lidocaine. Well, the problem there is we don't get any debridement, we don't reduce the bacterial count, we're not upregulating growth factors. I could write for collagenase, which is commonly utilized in treating wounds. So we get excellent debridement, but we're not going to get reduction of pain or increased vascular perfusion or reduced bacterial or fungal load or stimulate, say, epithelialization. Yet by compounding, I can mix, for example, lidocaine for pain reduction. I could provide collagen to act as a lattice work on which growth can occur. I could provide debridement with collagenase. I could add a calcium channel blocker to increase vascular perfusion. I could add an antibiotic. I could add an antiseptic. I could add an antifungal. I could add a medication such as phenytoin or atorvastatin to stimulate granulation tissue. So I could accomplish multiple things at one time. And the only way to accomplish that is by compounding. There are many, many FDA-approved wound care products, as you know, but when I look at that wound, I say to myself, not what product do I want to prescribe, what do I want to accomplish with that wound, determine the appropriate constituents of that product, and instead of writing for a pre-made commercial product that probably only allows me to do one thing at a time, I could go ahead and accomplish multiple things at one time. For example, phenytoin. We know that dilantin promotes granulation tissue. I could write for topical metronidazole, which is going to be helpful in reducing the anaerobic bacterial count. I could prescribe something topically to increase perfusion in that wound. I could write for misoprostol to decrease inflammation. So I could accomplish multiple things at one time by compounding. I could write for lidocaine, which will increase blood flow, reduce pain. I could write for pentoxifylline, which will increase blood flow to the wound. I could prescribe estrogen to increase rates of wound healing. So let's look at some examples. Let's take debridement. Collagen, or collagenase rather, is frequently prescribed by podiatric physicians for wound debridement. And it comes commercially in a fixed concentration, and it's a very excellent product. And there's lots and lots of literature to show that topically applied collagenase works well for many patients, either to perform an initial debridement or following debridement to preserve the effects of that debridement. But I'm limited to one concentration. When I compound, I can say I want a collagenase at a particular strength or stronger, and I could add other things for more effective debridement, such as urea or salicylic acid. The other thing I could do is mix that collagenase with, for example, a topical antiseptic or antibiotic or antifungal. I can mix that collagenase with something to increase blood flow. So if we look at collagenase versus Santyl, Santyl's an excellent drug and wonderful, very good literature to support its use. No argument about its clinical effectiveness. The difference is in most patients, want more than just collagenase. I want to accomplish some other things at the same time, and compounding allows me to do that. We have patients that have decreased vascular supply, particularly small vessel, and of course we're going to evaluate them and send them for appropriate vascular surgery or percutaneous angioplasties or stenting, whatever is required. No question about that. When we get down to that microvascular level, however, I can incorporate by compounding medications that will increase blood flow, such as lidocaine or calcium channel blockers or topical nitroglycerin or pentoxifylline or atorvastatin. So again, I could take a wound like this and say I want to increase blood flow topically, plus I may want to add an antiseptic or antibiotic, or I may want to provide collagen, or I may want to provide something to stimulate epithelialization. I may want to add something to reduce pain. So I could look at the wound and say, what do I wish to do? And I could accomplish all those things at one time rather than saying, well, what one product do I want to use for wound healing? I use a fair amount of lidocaine for two reasons. Lidocaine, as you know, is effectively a calcium channel blocker and increases blood flow to the wound, and it also helps to relieve pain. And this is helpful for dressing changes in addition, because we know that when patients have pain, they vasoconstrict and they decrease blood flow to the area. I can add topical pentoxifylline, which has been shown to be very, very helpful for sickle cell ulcers, arterial ulcers, and venous ulcers in particular. We have many, many dressings and many, many wound products that provide collagen to our wounds, and there's no argument that collagen can be extremely helpful in many ways in achieving wound healing. We have interactions between the collagen and the surrounding wound. We have the collagen acting as a lattice work for healing. And so there's no argument that the provision of collagen in some patients can be helpful in resolving their ulceration. And here again, I can provide collagen to that wound at the same time accomplishing other things. What about the stimulation of healing? We have all seen many, many products, skin graft substitutes, biologics, whatever one wants to call them, to provide growth factors and stimulatory cytokines, provide ingrowth of new cells, provide fibroblasts, so forth and so on. So this concept of stimulating new tissue growth in a wound is hardly new, hardly an original concept. But there are topicals we can utilize that have good literature to support their use for stimulating the growth of tissue. Probably the basic building block in my mind is phenytoin, generic Dilantin, the statin drugs, and to some extent Manuka honey. Now, statin drugs are something that we haven't seen discussed very much. All of us are familiar with the use of statin drugs to reduce cholesterol and certain lipoproteins, but it's interesting that there's a good amount of literature to show that statin drugs will increase vascular perfusion. It will eliminate the effects of vasoconstrictors such as angiotensin converting enzymes. It'll promote epithelial growth. It increases vascular endothelial growth factors, and so there are many, many benefits to topical statin drugs. And the laboratory evidence is there to show strong evidence of beneficial effects in wound healing with statin drugs. Generally, we're using concentrations of about 10 milligrams. High doses of statin drugs have been shown to be helpful in preventing recurrent ulceration. Phenytoin has a number of good studies to show that it stimulates epithelialization. We want to remember that one of the side effects of phenytoin systemically was gingival overgrowth, gingival hyperplasia, and we can put that to good use topically. It stimulates collagen production, stimulates protein production, stimulates basic building blocks of collagen such as hydroxyproline. Phenytoin stimulates fibroblastic activity. It increases certain helpful interleukins such as interleukin 1 beta, and increases the activity and function and number of myofibroblasts, which are very, very important for wound contracture. And there's an awful lot of good literature to support the use of phenytoin in wound healing for stimulation of epithelialization. Some studies have shown, for example, that pre-treatment of graft receptor sites with phenytoin increases the successful graft rate, graft take, utilizing phenytoin, both for split thickness skin grafts and allografts and xenografts, so that pre-treatment for common skin grafts or skin graft substitutes that we utilize in podiatry increases the effectiveness of those grafts when applied. Tremendous amount of literature to support the use of phenytoin. Decreasing ulcer pain. While many of our patients have neuropathic ulcers and are not painful, some have painful ulcers, and the use of local anesthesia is helpful for not only decreasing suffering and increasing quality of life, but again, you get a secondary vasodilation because you eliminate that pain-associated vasoconstriction. Typically, I will utilize 5% lidocaine, but really other topical anti-inflammatory or topical local anesthetics can be utilized. We speak a lot about reducing bioburden and wound contamination, and here again, instead of just applying a topical antiseptic or applying a topical antibiotic, I can combine my antibacterial or antifungal therapy together with other goals that I wish to achieve. So I could try to reduce bacterial count by utilizing any number of antibiotics topically. I can at the same time provide collagen, or I could stimulate epithelialization. I can vasodilate. I could reduce pain. So here, instead of just applying a topical antibiotic or a topical antiseptic, I can apply that same antibiotic or antiseptic together with other products to achieve other goals. Tea tree oil is discussed a lot in the literature for its antibacterial, antifungal effects, its anti-inflammatory effects, and here again, if you are a tea tree oil person, you'd like to incorporate this in your therapy, I can combine this with other products. So in looking at wound care, going back again and looking at the sequence of events that occur, the different stages of wound care, we can utilize a variety of topical products at different stages of wound care because we know that there's overlapping. We don't just have an inflammatory and a reparative and a remodeling phase. That at any given time within a wound, we may have various components of various stages of wound healing. So I could look at that wound and drive healing and manipulate that wound by saying, what is it that I want to utilize in that particular patient? Lastly, I want to say a few words about communication between the doctor and the patient and interactions with the healthcare system. I think that the most important thing is to get the patient to utilize the compounding medications, and I think we need, and that requires you sitting down and talking to the patient. The patient needs to understand their disease process. We see many patients, we all do, who really have very poor understanding of their disease process. I think they need to understand why you're prescribing a compounded cream. They need to understand why you're prescribing a medication that's probably not going to have insurance coverage. It's going to cost them money out of their pocket, and you need to sit down and talk to them and explain why it is they need this. The fact that you could accomplish multiple things at one time, whether you're treating neuropathy or treating a wound or treating Achilles tendinosis or treating fibromatosis, whatever. And that really, if you were to prescribe each of these medications individually, the cost would probably be worse. More importantly is that you're doing it in their best interest. Patients also need to understand how frequently to use the medication and how to use the medication. So these are factors. In looking at non-adherence, sometimes it's because the prescription was never filled. One of the things we find is that patients sometimes fill the initial prescription and then they stop taking it. And we don't call that non-compliance. We tend to call it non-persistence. And oftentimes this is just a miscommunication where the patient didn't understand that they need to continue their treatment for a while. And then we have tertiary reasons for non-adherence. Perhaps they come in, they say it's not working. We find out they're only using it once a day instead of 2 or 3 times a day. And I think that's very common. So in looking at compliance in general, not only for topical compounded medications, but just in general, there are a number of factors that we need to look at. We need to consider all these things. Oftentimes, it's not just a willful act by the patient simply not to follow our directions. And compliance is critical in getting our patients to utilize their topical compounded medications together with the other therapies we're utilizing, because it's rare that a topical compounded medication is going to be the only course of therapy. So it requires really good communication between you and the patient, and an understanding of the healthcare system and what's available and what's not. So your attitude and the patient's perception are critical, and they have to sort of come together in order to achieve good compliance. So in summary, I utilize a tremendous number of compounded medications in my practice. They have been extremely helpful in working with patients and reducing the frequency and intensity of their symptoms. I tried to review during this discussion the most common reasons that we utilize compounded medications in daily practice, and the indications for these, and hopefully this will be of benefit to all of you. I hope you seriously consider the use of topical compounded medications in your practice.